So I think we should start this session. This is a video symposium. When the going gets tough, the tough get going. It's an interactive video session where presenters, they present their complicated situation, and we have judges here, Dr. Namrata Sharma ma'am, Dr. Ramamurthy, Dr. Rishi Swarup, Dr. Gaurav Luthra. So they'll be stopping the presenters in between, and they can ask a question that why did they do things like this. So we come up with newer points and how that situation could have been handled differently. So we want audience participation also. They can also ask some question in between. And I'm sure that it's going to be a very fruitful session for all of us. Dr. Ghulam Ali, please come here, another judge. So first presenter we have Dr. Anaga Herur, who will be showing her case, Take the Bull by Its Horns, Bailing Out the Traumatic Subluxated Cataract. Please come here. So we have six minutes for each presentation, including discussion. Yeah. Yes, Dr. Anaga, all yours.
Thank you so much, Dr. Harsh.
And let me tell you, we have the prize for the best, toughest guy and toughest girl presenting in this session. So judges, please note. Thank you.
Thank you, Dr. Harshal, for the opportunity, and respected judges, a very good afternoon. So I would be speaking today on an interesting case, a traumatic subluxated cataract. So this was a 26-year-old male who had come to us with history of injury with ball while playing cricket, and his vision had dropped to 6/60. As you can see that there is a very gross subluxation as well as there is a cataract, so we had to operate him. So we follow all the tenets and rules of these cases. Now you can see how the zonules have been disrupted in that entire area. It's almost a 5 to 6 clock hours. In the area of maximum subluxation, we do a peritomy and a partial thickness triangular scleral flap. We could have also done a Hoffman's pocket, but we were more comfortable with this. Now I'm planning where to do the side port incisions. So I've done a side port incision on the other side also and done a capsulorhexis. As you can see, the capsulorhexis is centered on the lens with a very good margin because we need to put in a CTR ring also. Two other side ports on either side of the partial thickness scleral flap to have the capsular hooks onto the capsulotomy edge. And now very gently and meticulously, without any fluctuations in the anterior chamber, we are taking out all the lens material through a bimanual irrigation aspiration. Filling in the chamber with viscoelastic, I'm first putting in a CTR through the side port. And then as you can see, the CTR is from the left side with a long dialer or a Sinski hook. We are supporting the edge so as to ensure that the entire CTR goes into the capsular bag. The capsular hooks are now removed, but you can see that in spite of putting just the CTR, this is not enough because we know that this is a very large subluxation. So we will be now buttressing it with a CTS. So this is now the 90 proline suture is now already put through the hole of the eyelet of the CTS. It is put in through the main incision in such a way that the eyelet comes at the site of the maximum subluxation. Now the eyelet is always anterior and it comes anterior to the anterior capsular margin. We are using the 90 proline because Gore-Tex was not available at that point of time. And now through a bent 26 gauge needle which goes in through the partial thickness scleral flap, we are using the double-ended 90 proline suture through the main incision and railroading it through the 26 gauge bent needle. So this is the first one which has come out. For the second suture, we are repeating the same procedure, railroading the 90 proline needle.
Can you pause the video, Dr. Anaga? Once?
Yes.
Yeah. So I'll just like to ask Dr. Gaurav, Dr. Ramamurthy, that what is your preferred device here to take care of this subluxation? Sioni CTR or a CTR plus CTS like this?
So
and yeah.
I would actually do exactly what she's done. I would do a CTR plus a CTS. The order may change. Sometimes I would just during the surgery support the bag with a CTS and anchor it to one side so that I can operate and get.
Instead of using capsular hooks.
Sometimes, yeah. So it all depends, and I actually like to use capsular hooks, but sometimes the timing of putting the CTR can be variable. Sometimes I'll use the CTS first to fixate, and then I might just put the CTR later. But other times, when the bag is collapsing and everything, then I might just put the CTR first and then use the CTS to fixate the bag later on. It all depends on during surgery how it's going. But capsular hooks do remain, but I prefer to use the MST capsular hooks, which are much wider because they hold. Then you can delay your CTR insertion if you're putting the MST ones. With these kind of hooks, you have to kind of go earlier with the ring. I don't know what to tell.
I think a CTR, a CTS is not even required in this case. In the sense that it's though the subluxation is quite significant, it's a traumatic cataract where the subluxation are progressive. If it was Marfan's, if it was pseudo exfoliation, I would have definitely preferred that. But as you can see, once you put the CTR itself, the bag seems to be quite stable. And once you put the intraocular lens with the haptic submitting in that area, quite often it
but there was a gap. There was a significant gap. So once I take the suture, you can see how it comes to the.
So decentered, then it'll move. I mean, it may not subluxate further, but
I have had situations like this. It's of course CTR I've almost given up completely because CTS is so much easier to handle with a CTR plus a CTS. But many traumatic cataracts where the further zonular dialysis is not there, I manage with just a CTR and an intraocular lens also.
Namrata ma'am, Hoffman pocket or the scleral flap like this? What would you think will be a?
I would go for Hoffman pocket, and I would use a Sioni rather than a CTR and CTS in this.
In one go, you take care of all two things. Yeah. Okay. Fine. I think let's move ahead. Yes.
So now we are pulling in the sutures, and you can see now how the entire capsular bag, we can see how the zonules on the top are present, but inferiorly they are absent, but now the entire bag will approximate very well, and we can now stretch the bag completely. So the idea was that the entire bag opens up completely so that later on, because of capsular contraction, there should be no phimosis or decentration of the lens. The patient is a young boy, so we didn't want to take any chances. And then we are putting in a 3-piece lens. So here the eyelet comes on top of the anterior capsular margin and the 3-piece lens goes in, and it's well centered.
Dr. Anaga, again here, maybe from all the panelists, that would you prefer once you put in a CTR and a CTS?
Yeah, we could have put in a single piece.
I know you can, but I'm just trying to kind of create a discussion on one or the other, because getting a 3-piece into the bag and the injection and everything is more unpredictable with a bag which is already unstable, and since you've already put in a CTR and CTS, so the idea of putting the 3 pieces that suppose in future it dislocates, you can still fixate it. But if you already have a CTR in place, then it will serve as an anchor point anywhere and you're anchoring with the CTS. So in such situations, I actually prefer to put in the bag single piece lens which will open up in the bag, something like a 9x or something which you can do, don't have to do wound assisted injection, and you just inject the bag very, very predictably.
So for progressive zonulopathy in like Marfan's, you can use 3-piece, but for traumatic, as Dr. Gaurav said, you can safely use single piece in capsular bag.
And then we used glue to for the partial thickness scleral flap and the conjunctival flap.
Another recommendation is that these 3-piece lenses, when you're using, you can put them in the sulcus.
Yes, and then do
in the sulcus and just create an optic capture.
Yes.
That
so
also stabilizes the bag very
Post-operatively, the patient did very well with a vision of 6/9 and a very well centered lens. Thank you.
So I think that case was very well managed. Rishi, your comment? Anybody else?
I think all the comments that I could have said have already been said. It's beautifully managed.
Yeah.
Very little to change.
Okay. Thank you so
Thank
much,
you so
Dr. Anaga. Yes. So next we have Dr. Shilpi from Nagpur. She'll be presenting her case, Titanic, the sinking ship. So by the time it's set up, I'd like to ask panelists, what is your preferred suture nowadays to fix, like Gore-Tex or flanging? Because 9-0, 10-0, they degrade over a period of time. So what do you use to? Yeah. Anything, sir.
Gore-Tex.
Gore-Tex. Yeah.
How do you get Gore-Tex from the CT-based surgeons, or
Yeah.
is there a source now? Because we've been having trouble sourcing Gore-Tex. That's
We
Yeah.
have been getting it.
Huh?
We have been getting
Like,
it. I'll let you know.
okay.
Yeah.
Mumbai, yeah.
Yeah.
But problem with that, yeah, cost is a big problem. So yeah. Yes. No, it's a 10 box is costing 50,000, I guess. 50 or 60,000. Ah. So flanging is another good option, which I also started doing 6-0 proline, 5060. So I just put CTS, flange it, and flange it other side, yeah, with low temp cautery. So is there any problem there?
Dr. Namrata, like at RPC, are you guys doing flanging for some time? Or do you see patients who have been flanged somewhere, because you'll get all referred patients, right? So have you seen patients who have flanged and they've had problems with the flange over long term, like maybe 5 years or 6 years?
No, I can't.
Can't recollect any. So that
Can
means
I
it's not
remember?
happening. Right?
Okay, I think let's take Dr. Ashish Bajaj. By the time Dr. Shilpi sets it up. He'll be presenting a case of approach to traumatic absorbed cataract. Yeah, so Dr. Ashish is a prolific cataract surgeon from Chitrakoot. Welcome, Dr. Ashish.
Thank you, Dr. Ashwin. Thank you for this opportunity. And respected judges on the dais. So I'll be presenting a case of how to approach a traumatic absorbed cataract. Actually, this was a one-eyed patient. He was brought from our outreach and very reluctant to come. Actually, he had had subtle trauma a long time back, waited for his vision to drop, and then he finally decided that. So decided to do SICS in this. So made 2 side ports, stained the capsule. As you can see, the capsular bag is already fused. So I did not make the tunnel right away. First I wanted to handle this fused bag. So raised the flap with the cystitome and then went ahead with the Vana scissor, trying to maneuver this bag. So first aim was to clear the visual axis in this. So I couldn't go all around with the Vana, so decided to make a scleral tunnel.
Can you pause the video, Dr. Ashish? Yeah, any comments, Rishi?
I think, that doesn't look like there's much of cortical material also there. It looks more like fibrosis between the 2 capsules. Maybe just using a cutter and creating a large central hole would have sufficed, is what I feel.
Actually, I was to implant a rigid IOL in this case. So that's why I decided to go ahead with the scleral tunnel. Ultimately, I'll enlarge it with the cutter only at a later stage.
No, another option is that you can use do it bimanually using intravitreal scissors and forceps. So as you cut it with the scissors, you lift it up with the forceps and you cut it
bimanually.
The micro
on the
forceps,
micro
yes,
forceps
that's
and micro
yes,
scissors.
okay.
Even a rigid lens, I think you can easily put it in the sulcus.
So I enlarged the tunnel and now went ahead and approached. So once I had cut the capsule, I had planned to capture the IOL. So in fibrotic capsules, it's really difficult to capture. So you need a slightly larger opening. So at this stage, then I took the bimanual vitrectomy cutter to trim the additional excess margin or the fused capsular margin. There was vitreous prolapse also at this stage. So anterior vitrectomy was done. At our center, we have not started using Triamcinolone as yet, but we are planning to start it. There were extensive synechia there, so release them with the repositor. tried to make the sulcus fully patent so that I could push in the lens there. A lot of fibrous cortex there, but I couldn't get it out. Again, some amount of vitreous was there. So again inflated the sulcus and went ahead with a 3-piece IOL. Plan was to put the haptics in the sulcus and capture in the residual capsular opening. So it takes a bit of an effort as compared to the normal rexes to capture these lenses because the margins are fibrous. So you just have to nudge it below the residual opening, and you can see the ovalization of the opening there. So it's an endpoint that your capture has been done. So the ovalization of the capsular opening is an indication. Put in some pilocarpine to constrict the pupil. Wash the residual viscoelastic. So since this was a one-eyed patient and vitreous loss had occurred, so we always prefer to suture the tunnel in these cases. Also tend to suture the conjunctival flap over this. So at the end of the surgery you could see a well-centered IOL.
So very nicely managed, first of all. I would be just concerned about two things. One was that your capsular opening was broken at about 7-8 o'clock, and when you were doing the optic capture, I felt that it got enlarged also. So frankly, with a broken thing, and then when you do a capture of the optic, it's entirely possible that one of those haptics, especially that haptic, was very close to the area where the rexus was broken, right? I mean, so, and it was not a very fibrotic rexus in that area, so it was kind of like looking very flimsy. So there's a risk that that haptic will, also follow the optic and go behind and could dislocate at a later point also. So I might have not done the capture in this patient, right? Because if my thing was absolutely intact, I would have done the capture. But if I have a broken rim and a fibrotic capsule, there's a good chance. Second, how did you, I mean, you did a good anti-vitrectomy, which is obviously very necessary. But also sometimes in such situations, if you leave viscoelastic behind the IOL, it gets trapped and can set up lots of problems like inflammation and even pressure spikes. So I'm not saying that, I mean, I'm sure you did a great job and it came out good, but for the benefit of the audience, it's also very important that whatever visco goes, please don't use a lot of viscoelastic because there will be some scleral collapse, and if you do too much of a vitrectomy, sometimes there's a lot of space, and then that retained visco will set up a situation. So I think these 2 points I wanted to just.
I think just following up on what Gaurav said, visco invariably goes in these cases through an open capsule. So before you create an optic capsule using a bimanual IA, once an adequate anterior vitrectomy has been done, keep the irrigation cannula in front of the lens, go behind the lens, and just flush, and then the entire visco gets aspirated. You can actually see the strings of visco getting aspirated. Once it's cleared up, then of course you know that it's completely evacuated. And I think for an institution like yours, you did mention it, but I think to send a message across, triamcinolone acetate is mandatory. The pupil is absolutely round and neat, so most probably there are no strands, but oftentimes I've been surprised. I think that rexus margin is clean, that the pupil is round, but then put a drop of diluted triamcinolone acetate, and you find the strands of vitreous which could have been killed right away. I think anywhere where you think you are dealing with vitreous, it's always a good idea to use as
right.
I'll just add one more point, since you did a very good thing about putting a prophylactic suture since the patient is one-eyed. Another thing you could have added is intracameral moxifloxacin in the end, because loss of vitreous is a risk factor for endophthalmitis.
I have not put it in that, but we give in all our cases intracameral. Thank you.
So, yeah, ma'am. Okay, fine. Thank you. Thank you so much, Dr. Ashish.
Thank you.
And next we have Dr. Shilpi with her presentation. Yes. So let me introduce Dr. Shilpi is from Nagpur, and we know how much hard work she does for ARC. Thank you.
Good afternoon, everyone. So thank you for this opportunity. So this is a routine case of rhegmatogenous retinal detachment posted for standard pars plana vitrectomy. After doing the vitrectomy, ileum was stained with brilliant blue dye, and the ileum peel was initiated using the pinch and peel technique. Because of the fluid, the macula was cystic. And oops, at a point, there was de-roofing of that cystic macula. So the situation was assessed, and the ileum peel surrounding the de-roof cyst, it was peeled in a centripetal fashion. Following this, rest of the vitrectomy was completed. PFCL was put to flatten the retina. Endolaser to the brakes, and then followed by fluid air exchange. So the fluid air exchange was run through the peripheral brakes and also through the iatrogenic brake which was created. And then the 360-degree barrage laser was done, and the oil was put.
So what, as a cataract surgeon, I can tell you is the view was mesmerizing, and music, background music was so soothing and hypnotizing. The rest, Dr. Gaurav will tell. Yes, Dr. Ramurthy.
That was 30 years back. We didn't have any devices like this, yeah. Anyway, great job. What was the vision the patient got?
So,
You don't talk about it.
sir, after retinal detachment surgery, 636 was the vision he gave me. Yeah.
No, that iatrogenic brake was the
It was
mistake
paramacular.
that was done. Iatrogenic brake was, for us novice eyes, it appeared as if it was done a little too briskly. Could it have been avoided? What do you
Yes,
think?
sir. It could have been avoided if we could have put the PFCL initially. If there is too much of a cystic macula because of the fluid, one thing is you can initiate the ileum peel and then flatten the retina, and under the PFCL we can do the ileum peel. So then it could have been, yes.
Okay. Thank you very much, Dr. Shilpi. So next we have Dr. Shivani Patnaik from Mumbai. She'll be sharing a case on posterior capsule dehiscence in posterior polar cataract. Is your video there?
Yeah.
Okay. Please go ahead.
Good afternoon, everyone, esteemed judges and the panelists. Thank you for this opportunity, sir.
Polar with pre-existing dehiscence. The slit lamp examination will not reveal the real story. AIOCMT shows and confirms the diagnosis. Real story. AIOCMT shows and confirms the diagnosis. The slit lamp examination will not reveal the real story. AIOCMT shows and posterior polar with pre-existing dehiscence. The slit lamp examination will not reveal the real story. AIOCMT shows and confirms the diagnosis. Patient taken for flags, CCC planned for 5 mm, and the posterior safety distance is increased away from the posterior capsule. Also,
Can you pause it?
Yes.
No, what did the ASOCT show? Was
So,
it an intact PC or
it was a breached PC. I'll just go back. So there is already a dehiscence in this area. I think
But there's no lens matter in the anterior vitreous area.
yeah. So we are not sure of the lower half. I mean exactly at the pole we were not sure of it. So that is why we decided to yeah. Yeah, it's very strongly adherent is what we thought. So during the case, as the events turned out, it turned out to be a the dehiscence was already there.
confirms the diagnosis. All steps, CCC, fragmentation and clear corneal incision are done by flax.
That ensures a proper CCC. So
The capsule is pinched out. No hydro procedures are done. Clear corneal incision are done by, and the posterior safety distance is
that's the safety zone. Yeah, so we have extended and we have kept a safety zone above and below. Below doesn't matter. Above, we didn't want a very huge, thick epinuclear plate, but we have kept it to around 700.
What's that, on that right image, there is that pink line which seems to be what the laser thinks is the posterior
This is the
capsule.
OCT image that the machine has captured.
But what's that, why is that orange thing extending much below it?
This is a safety zone. It
Oh,
extends
okay,
above and
so
below
above
of
and
the
below,
laser.
so
It
right,
doesn't,
right.
yeah,
Got
the
it.
laser won't hit in that area.
Got it. It's different from the catalyst, that's why.
Yeah.
increased away from the posterior capsule. All steps, CCC, fragmentation and clear corneal incision are done by flax.
So we went ahead with fragments and we did a CCC.
The capsule is
So
pinched
the
out.
CCC ensured
No
that
hydro
we
procedures are done.
good support in
Bimanual
case
IA
of
is done directly.
with an
No
optic.
rotation is attempted. Since it is a soft cataract, no phaco is really
patient and there was not much nuclear matter. So in this case, we kept the bottle height and the parameters very low, considering that any fluctuations in the bag would lead to a drop. So since we had a thick epinuclear plate, it was slowly and steadily that we decided to peel off the nucleus, and without losing the bag integrity, we kept on injecting viscoelastic so that the bag doesn't collapse.
make sure that all the soft cortical matter around is as
No cylinders, only 6 fragments, 4 fragments. No, that's the hydrodissection. Only
You can do
4
6
fragments.
jobs, but if you do cylinders also, 2 or 3 cylinders, then those pieces, they become like pies,
Which can be taken out easily.
So why did you use a phaco probe to kind of just take that central material instead of doing a IO?
The nuclear material was very soft, so the chances of a crater being formed then further complications, that's why.
aspirated
So you,
before the
Dr.
central
Shivani,
part
you
is
always
angled.
keep your side port at this in
Yes.
this location.
Yes. It's easy to maneuver 360 degrees. I mean, this is as per
No, but if
comfort.
it's 180-degree apart, I think
Yeah.
that gives a better access and give better centration of the eye also.
Okay.
Because but then there is no subincisional as such, So you need to angle your cannulas like
Yeah,
this.
yeah.
I can see that. Yeah. Okay, please go ahead.
So essentially we were left with the central adherent PPC. So we tried to hydrate that area, we tried to slowly peel it off, but eventually it was going to tear is what it seemed. So essentially when you can see that the PC is being pulled along with the plaque, there are folds on the PC, and
soft cataract and it can
so while it was coming off, there was a dehiscence which we
all
saw.
the cortical remnants are removed. The plaque is
Can you pause it here?
Yeah.
Dr. Gaurav, would you like to go and viscose
So
dissect?
exactly,
at
I was
this?
saying that never peel these things, never trying to pluck them or peel them. the best way is to just go into visco dissection, right? Even, a passive flow of fluid like BSS also will sometimes float it up, but visco is the best because if you just start putting visco from various sides, it'll end up kind of separating it without any pull on the PC, because the PC tears, it's very thin and very also adherent. So the moment you pull it, it's going to just kind of break. But visco dissection works wonders.
And moreover, the visco is going to plug that defect which is there. Yes,
coming to that, even more than HPMC, I would like to use visco.
Visco, yeah.
So that also tamponades the anterior space plus dissects the.
Please.
One can see that all the cortical remnants of the plaque is held with the aspirating port and all around gently elevated from its attachment. One can also see the dehiscence in the posterior capsule which is present and which was diagnosed preoperatively with the help of the AIOCMT3. The plaque is then detached completely. With the help of the aspirating port, the plaque is gently elevated and making sure that no vitreous is, with the help of the aspirating formation, with the help of the viscoelastic chamber is not allowed to collapse at all. And once that is done, we made sure that the vitreous did not follow the plaque. Since the rest of the capsular bag is intact, and in the bag IOL placement and rotation of the IOL is achieved, the rest of the cortical matter is removed once the lens is placed horizontally into the bag. So with the help of advanced technology like FLAX, let's look at the first day post-op image. You can see the lens in the bag and a well-centered IOL. Thank you.
Thank you.
Anything?
Which IOL is this?
J&J Hans.
No,
EDOF.
but there are holes in the. You created the holes?
No, it's EDOF, yeah.
No, but did you create the holes at the haptic optic junction? They have holes. They are dialing
No,
holes.
there's nothing created. Maybe it
Just
was
see.
a...
I mean,
Yeah.
Posterior pola with pre-existing. Since the rest of the capture is
see some
removed,
holes on the
Yeah.
haptic optic.
once the lens is placed
no, it's
horizontally
To
into the
special
bag.
to kind of anchor it.
So with the help of
No,
advanced
no,
technology like FLAX,
maybe I-
let's look at the first day post-op image.
comfortable.
You can see the lens in the bag and a well-centered
No, I was thinking
IOL.
if just in case a single
Thank
piece
you.
lens, you end up needing to suture it, you can just pass a suture through that.
Capture also with it.
Yeah, we could have.
Posterior axis with the optic capture because that's a small PC
So, would we do a PCCC in this case to, already the defect is pretty circular and there's no vitreous.
Shivani, if you go
Alright.
back to the end, no, there is a little bit of a traction on that round hole.
Yeah,
So there's possibility that there's a vitreous adhesion there. Sometimes that can cause traction at the vitreous base and it can cause a break.
okay.
So perhaps maybe a good idea to actually put triamcinolone and
At the
check.
end and check.
Yeah, and if you have, then maybe good to do an anti-vitrectomy as well. And of course, you have to screen the peripheral retina and make sure there's no bleeding.
Okay.
So wherever you see irregular tears,
Hmm.
you definitely have to do PCCC and make them regular,
Hmm.
so that it doesn't tear off in periphery, once you're putting IOL.
Yeah.
So that's the importance. You convert it into PCCC, and you go ahead and put a single piece IOL.
Harshal,
like this. Yeah.
in these posterior polar cataracts, capsule is so thin and
Yes.
very difficult to it's not very easy to convert them into PCC. So I'm
I
thinking that, whether it's a good idea to just leave it if it's a small one with some
No,
scarring.
but she had
But-
a small tear to begin with,
yeah,
but
true.
while putting the lens, it enlarged.
It enlarged.
So
yes.
had she had converted first, it doesn't enlarge.
I think she had been quite fortunate. Most often these PCC,
They
when
go
it
through
is
and through,
split,
yeah.
it will be one pole to another pole.
Yeah.
That actually is also a good thing in the sense that it doesn't extend. And you have two flaps of posterior capsule where you can place your intraocular lens. But in her case, it was a nice round
Yeah.
fibrosed rexus
Point
margin
out.
that was there. And what Rishi is pointing out, I thought there was more of striae on the capsule, but still I would always recommend that putting in a drop of triamcinolone and testing it. But we also started doing this routine use of AIOCMT3 for all these cases. And a very thick plaque like this, even though there might be an intact PC, sometimes you are not able to make it out because it appears anechoic. It doesn't go through the very thick plaque. Secondly, you might sometimes have very tiny holes in the posterior capsule, because of which it appears deficient. Or it might be an extremely thin but continuous posterior capsule. You have to be very careful about it, but it's fortunately has a negative connotation in the sense that even though you might think that the PC is not there, we are pleasantly surprised that it is intact. But if the PC definitely seems to be intact, then you are on, and we nowadays start handling those cases like a regular cataract surgery where we go ahead and hydrodissect, rotate the nucleus and do everything.
So I think we've described the sign, the disc sign. So the disc sign is there, that means the PC is intact. And second is if you do have intra OCT microscope, and Gaurav would agree, then it kind of helps to refine your surgery better. But I agree with Dr. Ramamurthy completely that the kind of defect that was there, and the case was handled well, otherwise it could have gone into a better like this also.
Very nice, Shivani. Thank you.
Sir. Thank you, sir.
So next we have Dr. Gunjan Buddhiraja, a young surgeon from Delhi. And after that, Dr. Arvind is there. Yeah. So
This doesn't feel like a court martial. This feels more like an appreciation.
so these are all tough guys and girls who have already done good job in OT.
I think I'll get. There's no video here, sir. Video, sir. I'll get mine.
I think by Dr. Arvind, you can come by the time she gets her laptop. So next we have Dr. Arvind Moria.
Yeah,
Will
please
be-
play.
Greetings. I am presenting a case of Sturge-Weber syndrome who was one-eyed with complicated open-angle glaucoma. This patient was in his late 30s with bisymptomatic encephalotrigeminal angiomatosis. His one eye was PL negative after multiple failed trabeculectomy and drainage device placement. Other eye was having tunnel vision, 6/18 and on 5 anti-glaucoma medications. So, the routine trabeculectomy is associated with multitude of complications including choroidal detachment and hypertonic. Placement of valve is bulky and costly. Hence, we plan to implant a Make in India Omniflow drainage device in his only functional eye. This is how this 50 mm length with 0.3 into 0.7 mm drainage device looks. Retrobulbar space behind the equator is almost free from myofibroblasts. Therefore, it is virtually free from fibrosis even without mitomycin C and can drain up to 500 microliter per minute. After putting a L-shaped cut in the conjunctiva and after little blunt dissection, a wire vector was inserted to reach retrobulbar space to make a track for this device. Up to 40 mm of wire vectors can be inserted with ease to create a track. Then about half of the tube was placed with the walled distal end into the retrobulbar space that goes quite smoothly. After this, the tube was primed using 27 gauge hydrocannula to check the patency. Gentle and minimum wet cautery was performed. This was followed by partial thickness markings on the sclera using a MVR plate at 5 to 7 mm away from the limbus. Then a scleral tunnel was made with 23 gauge MVR blade. This tunnel was properly lubricated with 2% HPMC. The proximal end of Omniflow was now inserted and passed through the scleral tunnel after few attempts. Then the proximal end was sharpened by cutting it obliquely using a scissor. Now a second scleral tunnel was made which was radial to the limbus up to 2 to 2.5 mm from behind the limbus, which was then gently entered into the anterior chamber, bisecting the angle of anterior chamber and the iris. Intracameral pilocarpine was pushed into the AC. Now, the beveled end of the Omniflow tube was inserted into the anterior chamber via the second scleral tunnel. Utmost care was taken so that only the beveled 1.5 to 2 mm end goes inside. Then the excess band of the tube was pulled back and slowly pushed back into the retrobulbar space. The Omniflow device remains firmly in the two tunnels. Finally, the conjunctiva was well opposed using few interrupted 8-0 Vicryl suture.
Or even
During the post-op period, IOP came down to 12 mm of Hg with only brimonidine eye drop in continuation with best corrected visual acuity of 6/12 and was maintained till last follow-up of 8 months. So, OmniFlow is a short shunt and the best glaucoma drainage device to drain aqueous from AC to the retrobulbar space by preventing hypertony and keep IOP between 10 and teens 24/7 with least use of anti-glaucoma medications. OmniFlow will revolutionize the management of all types of primary or secondary and intractable open-angle glaucoma, neovascular rubeotic glaucoma, silicone oil-induced angle recession, posterior embryotoxin, and glaucoma in Sturge-Weber syndrome in a most cost-effective manner without trabeculectomy and use of mitomycin C. Thank you.
So there are no complications which are associated with trabeculectomy with this device, like the choroidal effusion, the detachment, and the CME.
How many cases have you used it in?
113 cases.
And have you compared it with?
Yes, we are comparing it with the trab with mitomycin C. The study is going on.
This very ingenious device, it just seems to be a simple catheter. I mean, if it works, it's great. So, is it any different from a small, what's the inside bore?
It's a Teflon valve fitted that we need to put it into the retrobulbar space.
So, no, what's the internal bore of this?
It's 0.7 into 0.1, and the Teflon valve is 175 to 250 microns.
It's a valve
Yes,
device?
it's a valve fitted at the retrobulbar end.
The valve is there to avoid excess flow?
It works on the principle of this Bernoulli's. So minimum back pressure of 10 to 15 millimeter of Hg will always be maintained in the anterior chamber.
So why shouldn't it maintain all trabeculectomies? I mean, replace all trabeculectomies. This could become the
in last 4 years now we have more than 1,000 implant all over India.
How does it differ from AGP?
It's totally, the principle is totally different. It's very small, whereas that is very bulky. Right? And the principle is different. So what we have, after a lot of research, it took us 6 years. It's team of Kakadia sir, Shah sir, me and Dr. Satish D. Sheth. So we were able to titrate the capillary diameter that will be sufficient to maintain the back pressure in the anterior chamber. So finally we come out. And this 175 and 250 micron, it works very well. So 15 millimeter of Hg will always be maintained. That is the beauty. So there is no hypertony, no, in not a single case.
And you did mention that the fibroblasts are not much in that area.
Yeah, the retinal surgeons are exploiting that space long, since eternity. They are exploiting this place because it's absolutely almost free of myofibroblast.
So no need for a mitomycin C.
Yeah, it's not required. Not required. We can save the limbal stem cells also. Mitomycin C not required. Even pediatric ophthalmos cases, we have implanted 27 cases working very well as a primary treatment.
Are you using it also in place of routine trabeculectomy?
Yeah. Now I have stopped doing trabeculectomy. Yeah, I have stopped doing trabeculectomy. Only in the angle closer, I am doing trabeculectomy.
The cost of this device?
8,000 plus GST, available with Excel Optics Private Limited, Chennai.
Why 8,000?
Research took a lot of time and energy and money, so.
You have patented it?
Yeah.
So I thought of making one of my own.
You are most welcome in our other innovations.
Okay, thank you so much.
Thank you.
Dr. Arvind. Do you want it back, Dr. Arvind?
Yes, 3 year, it was only 4.3, it's maintained, it's not much, no.
Do you want it back, Dr. Arvind?
No, you can keep it.
Dr. Ramamurthy wants
Yes, I will share you more samples. Anyone want?
He wants to give for
But
Dr.
if you're
Chitra.
putting it in the retrobulbar space, then there must be, there are no side effects or nothing like that?
Yeah, no side effect, no. So though we need to measure the how much tube we need to implant. So the formula is axial length plus 5 millimeter. Under microscope, you will be able to see.
No, but then this appears to be too
So
simplistic.
the formula is axial length plus 5 millimeter. Rest of the part we need to cut it.
Okay, thank you so much, Dr. Arvind.
Yeah.
So next we have Dr. Gunjan Buddhiraja with her video.
So at the outset, I would like to thank IOS and all the panelists here. So I'm presenting a case of a developmental cataract of a young patient of 21 years old. She had an anterior capsular adherence, which I'll be showing here in the video. So this is the cataract, developmental cataract. So I made the side ports and I'm stating the capsule here. Now I started making the rexes and then switched over to retro illumination, and slowly I'm pulling out rexes, folding up. So here I'm having a little bit of feeling of that the rexus is running away. So I try to fill up the viscoelastic into the anterior chamber. But here I get a rexus extension at the end of the rexus.
Can you, Gunjan, can you just go back?
Yeah.
Yeah. More. Before it happened. Little more, yeah.
What is the age of the patient?
21 years old.
Little back. Yeah. Dr. Gaurav?
You're talking about like where it ran away?
Yeah.
So, I would have probably managed differently, but maybe, you can ask what were you trying to do, like when it started running away?
Yeah.
What was your thought like?
So I was trying to get the AC filled and try to pull it into the center so that it doesn't run away. Also, I did not fill up the viscoelastic to that level that the AC was quite out. So that was I was trying to.
So I think two things that could have been done here. One is that you should have then, once you have a problem like this, it's no longer a great idea to continue with the cystitome. You should switch to a rexus forceps, and preferably a micro rexus forceps from the opposite side, from a side port, so that you have better control. And then other thing is that if it's not really fibrosed, you can easily bring it back with the Bryan-Little's maneuver. That really works well, rather than trying to push it in. In fact, it's counterintuitive, and you can just put the Bryan-Little's maneuver, and then it always comes back. Even with pediatric cataract, it works beautifully well. So these two things, and otherwise, of course, you did everything right. But when you start thinking that it's going out of control, then it's best
now
to go
I've
like
started doing it. Actually, this time, sometimes when we are operating.
So, for case like this, I would begin with the micro scissors and a micro forceps, and lift, and then cut, lift, and cut, lift, and cut. Because what will happen is, in between those fibrotic areas, you'll be able to tear, but the fibrosis you will not be able to tear.
Yes,
so cut it,
Right.
and then again tear, and then cut.
Yes.
So something.
Right.
What was the cause of this cataract? I mean, what kind of a cataract was this?
Developmental cataract, sir.
Okay, because it looks a developmental cataract. So what about the fellow eye?
I don't think those
Those
are
right,
fibrotic, no? Those are just in the cortex, isn't
Yeah,
it?
it's in cortex.
No, but there was a little bit when the microscope quality that I was operating in the peripheral center was not that great. So, but when I'm trying to get it here, it's not. Yeah, it's little fibrotic.
It will not tear, so that means it's kind of.
Yes.
Do you by any chance have access to a LRC's platform?
Sir, actually, I'm operating this cataract in a peripheral center,
Okay.
but we are operating under a good microscope, and now I'm we are
No,
having a
because,
good, yeah.
I mean, just as an additional point, this is a kind of a situation apart from the intumescent cataracts where the LRCS, though it doesn't create a free-floating rexus,
Yes.
creates a nice little template,
Yes,
and
sir.
you're able to take it out much more
Yes.
easily.
Yeah, please go ahead. So at this stage also, when you see Dr. Gaurav, when you see it has gone beneath the pupillary margin, I think you can still go there, check with
Yeah.
Kuglen Soak, where the extent, you can always try a quick pull once.
Yes, yes, sir.
Recently I showed, I saw one of the case Dr. Saurabh Patwardhan showed in Moscow on same case. It had gone beneath, but they could able to retrieve it back.
Yeah.
In fact, if you use viscoat in that area, it'll push the iris away, and it might even give you visualization even without a Kuglin Zook or a wide tip manipulator.
Yes.
And then you can kind of do the Pran Little's maneuver and pull it back. I have a good video like that, so I can kind of relate to that.
So
And,
even
this
if you
is-
look at, sorry, I'm so sorry.
Yeah, yeah.
This is what actually Rishi's idea, and I completely concur with that. There seems to be a central plaque and peripheral areas of fibrosis.
Yes.
In between, there seems to be a fairly clear cortical area. Maybe if you had made the rexes a little smaller and run it
Yeah.
without going into those fibrotic patches, might have got a
Agreed,
more
sir.
complete
Agreed, sir.
rexes.
After when I just saw
The central one is a fibrotic patch in the center.
Yes,
Plaque.
ma'am. Yes, ma'am. You can actually look here at when this is.
We are not letting her
full-
complete the case. Actually, you carry on.
Yeah. Carry on, Gunjan. Yeah.
So, sir, just wanted to add one point here. One was that I could go ahead with the FACO because I was just looking at Dr. Rohit Om Prakash et al.'s flap motility sign, where I can see the flap still fluttering. So I think that is what kept me pushing to start with the FACO and just keep on doing it here. And then I just did a very careful IA here.
See, another point is Gunjan, never come out like this suddenly, you know. So because that tear which is only there till equator, you may have a wraparound
Yes.
at the same time.
Yes.
So always maintain closed chamber till the end. Yeah.
Yes.
Started constructing Gunjan, so you should have instilled Phenocaine Plus at that point of time. Better visibility of this cortical removal.
The IOL is implanted inside the bag and checked that it's in the bag. The IOL is suitably in the bag. Thank you.
I think this case was very nicely managed. Very nice, Gunjan.
Thank you.
Anything to add from Benlist? Thank you.
Thank you,
Thank
sir.
you, Gunjan. So next we have Dr. Ridya Mohan with, I think, intumescent cataract. It's here? Okay, come.
Good afternoon, everybody. I'm Dr. Hridya. Morgagnian cataracts with a turbid anterior chamber may look very alarming preoperatively, but just washing off the anterior chamber can clear the view. In any case of small pupil, I prefer using iris hooks because you never know the status of the zonules in these hypermature cataracts. As in this case, which looked perfect preoperatively, as I proceed with rhexis, I note an area of weakness inferiorly. There is resistance to performing rhexis, and you can slowly see the zonular dialysis appearing, and I have a rhexis extension in this area. So in Morgagnian cataracts, I prefer using a spiral rhexis, starting small, then going spirally, avoiding areas of calcification in the anterior capsule. This kind of helps in preventing a rhexis extension even in the presence of loose zonules. Coming to nucleus emulsification, the major challenge that I faced is the extremely mobile nucleus which keeps moving and tilting, so you cannot get a good hold of the nucleus, as a result of which the chop is ineffective. So the solution is to stabilize the nucleus with a second instrument, bury the phaco probe in really well, and perform a horizontal chop so that you get a through and through separation. And these nuclei, although very small, they can be very leathery, so it is always safer to perform multiple chops prior to emulsification of the fragments. In this case, with very loose zonules, you can clearly see the dense matter that has seeped into the vitreous cavity. The bag was very floppy and it was coming into the phaco probe. So when performing emulsification very slowly in a more anterior plane with a lot of dispersive viscoelastic to push down the PC. IOL scaffold can be useful in these cases of floppy bags prior to emulsification of the last few fragments, so that the IOL pushes the posterior capsule down and prevents it from coming into the phaco probe and creating a hydrogenic PCR. This is a case of hypermature sclerotic cataract. It was impossible to perform rhexis using a 26 gauge needle, so I create a small hole in the area without calcification and proceed to fashion a circular rhexis using a 1-hour scissor.
Yes, sir.
Take mic, Rishi. Take mic.
So when you're doing one side and going to the other side, it may have been better to actually go for a micro-rhexis, and you would have gotten better access.
I know, sir, but it was not available in the peripheral center. That's why I had to go.
Or you enlarge your side put and go for it. You get a better control.
Yes, sir.
The area opposite to the subincisional area, there is dense adhesion and it is not accessible to the vena scissa, so I use a vitrectomy cutter to cut off these adhesions. Simply pulling the capsule in this area can cause an extension of rhexis. Here, after using the cutter, the rhexis is completed in a circular fashion, and the rest of the case goes unevenly as planned. In extremely loose bags, manual small incision cataract surgery can be quite effective, and after thorough vitrectomy, an iris claw lens can be implanted with good visual outcomes.
Thank you.
Thank you, Dr. Ridya. I think you covered almost entire spectrum of
Morgagnian
cataracts,
cataracts
how difficult they can be. There is one more situation, like there may be that zonules are so weak and not able to chop the nucleus. In that case, what you do is put a CTR ring.
Yes.
Yeah. So that stretches the capsular bag and then you can easily chop the nucleus. That was the only thing which was missing in there.
Very nice clutch of cases.
Thank you, sir.
The only thing I would have done, maybe in your first case especially, when there was so much space, I would have put the IOL scaffold much earlier than that.
Yes, sir.
As you rightly pointed out, many of these capsules are quite fragile, and they always have a tendency to come towards the phacoprobe, and there's enough space created once that liquid milk comes out.
Yes, sir.
And you can
It was
implant
a
the lens.
very small nucleus, sir, so I thought I could just eat it off and then.
That's
put
what
in
is
the-
more dangerous. I mean,
Yes,
that keeps rolling around all
Yeah.
over. You don't get a good purchase on that.
Yes, sir.
And then once you have the intraocular lens in place, then
It's safer.
of course, a lot of dispersive viscoelastic has to be used.
So,
Anything to be added? Okay. Thank you so much, Dr.
Thank you,
Vidya.
sir.
So next we have, I think, last presenter of this session, Dr. Subhashini. We all know that the softer cataracts are much easier to tackle than hard cataracts, so she'll be showing the technique for that. Can you have a video, please?
I'll just.
Okay, fine.
Respected chairperson, judges, and the audience, good afternoon. So I would be presenting a technique by which we can handle the soft cataracts, especially when they have, or the cortical cataracts when the nuclear component is very minimal. So it has a voiceover. Phaco in moderately hard and super hard cataracts is pretty straightforward in present times due to the availability of advanced phacoemulsification systems allowing for quick surgery completion. Here you can see the typical stop and chop technique used for moderately hard cataracts, where the nucleus is impaled with a burst of phaco, and with high vacuum the nucleus is chopped into smaller pieces. Can we use the same technique for soft and cortical cataracts? Let's see what happens. Here you can see the surgeon trying to impale the nucleus with phaco energy and vacuum, but he is unable to get a good hold of the nucleus. All his attempts are futile in getting a good effective hold to chop the nucleus into smaller pieces. So we devised a method to overcome this problem. This we call it the stop and silently chop technique. In our technique, the phaco probe is simply pushed into the heminucleus after the initial trenching and cracking, and here we do not use any phaco energy or vacuum. After one heminucleus is split into two halves, the other heminucleus is removed in the same way. So the probe is inserted into the nucleus, and the second instrument, which is a chopper or the Sinskey hook, is drawn towards the probe. After splitting them, the individual pieces are aspirated. This is another case to show you the same. See the surgical overlay, the vacuum is at 0 and the CDE, cumulative dissipated energy, does not increase. So it's just mechanically chopping with the probe and the...
After splitting them into multiple pieces, the individual pieces are aspirated. Vacuum is completely avoided to prevent aspiration and cutting through cheese wiring, and this ensures effective nuclear holding. Probe is pushed into the nucleus and the Sinskey hook is drawn towards the probe. You can make it into multiple pieces. How this helps? The advantages are it saves time, saves phaco energy, and saves
surgeon's energy. So in cortical cataracts, think of stop and silently chop technique. Thank you.
Thank you so much, Dr. Subhashini.
Thank you.
Rishi? Your comments, Rishi?
Beautifully managed.
There are techniques for with zero phaco, but not with zero vacuum.
All the cases that you showed, soft cataract can be an enigma, and all of the techniques were shown. So I think we'll decide any question, or should we? Huh? No questions.
No, I think it is very well shown, whether hard cataract or soft cataract. I make always a small trench. And in these soft cataracts, without using any phaco power, just try to chop. But in case the first time I'm not getting a chop, I just extend the trench, make it into a deep one, and then divide it and then proceed with the rest of it. Don't keep on persisting with chopping more as a ego issue. And then just go ahead and split it.
Yes, actually, as hard the cataract.
Once the backbone of the nucleus is broken, whether it's soft or hard, then the rest of the conquest is quite easy.
Yeah, the harder the cataract, actually, now as phaco surgeons, all of us are able to manage. It's the softer cataracts which have a tough call. Thank you.
Thank you so much. And with this, we come to end of this session. But we have some awards to be given by judges to best presenters in this session. So by the time...
We have to, 1, 2, and...
Ma'am, 3 in this session, and then scientific committee can give whatever you want, ma'am. It's on you. And we know madam is
very
big-hearted. Yes. So I think that's a very tough decision to make.
I think all of them were so good that this is a standard line, but I have to say it genuinely that it has become difficult to decide. But I think Anaga's video was the best.
So
followed by Shivani and followed by Iridya.
Oh.
Huh?
Okay, so I'll request Dr. Anaga to please come here. साइक्लिंग होके फिर नेक्स्ट को जाएंगे ना